Wonderful. Okay. Kenneth, take it away.
Great. Hi, all. It's a pleasure to meet everyone. It's nice to be here today. I am Kenneth Davis. I am a senior manager for growth at Frame. And Frame is a technology company and small business based out of Arlington, right outside of the Washington, D.C. area. And since we're a pretty small group today, I'm going to give a presentation that I'm going to try to keep pretty short and then kind of jump into a demo. But because we're a small group, if you have any questions throughout, please do feel free to raise your hand or jump in. And I'm happy to answer any really relevant questions that are helpful for kind of understanding what we're doing or anything like that. And then I'll be sure to pause throughout and give time for questions as well. I'm going to go ahead and share my screen. All right, so basically, Frame, what we do is we allow our partners all around the world, anywhere in the world, to zoom in down to the neighborhood level and see what people look like, what their characteristics are, what their attitudes and behaviors are. And we use this, you can see one example here, to unmask the data, the heterogeneity of data that's missed at aggregated levels. So we're often just looking at national level data sets. A lot of the common surveys we're familiar with, if they're not at the national level, they're usually not below the first administrative level in the country. You can see here in Kenya, this is a map actually of looking at one great open data source, which is the Demographic and Health Survey. So these are the USAID supported demographic and health surveys that are run by countries around the world. This is the 2003 and 2014 DHS in Kenya. And what we've done is map down to the 1 square kilometer level some of these statistics, some of the questions that were asked in those nationally representative surveys. And you can see what we had in the original surveys was basically child marriage rates in Kenya in 2003 were around 26% nationally. But by 2014, they had only gone down by 1 percentage point to 25%. What we'll be able to see on this map is these areas of green in the country at the neighborhood level are percentage point swings of a lower 25% in child marriage. Whereas these purple areas here are an increase of 25% in child marriage. So while it looked like between this over 10-year period, child marriage hadn't changed much in Kenya, what our data uncovered was that actually child marriage had shifted considerably, especially in reducing in more urban areas, but increasing in more rural areas. And we also looked into a number of the kind of underlying or at least correlated variables. Expected things like women's education were very closely associated with lower education rates, higher child marriage rates. Another quick example, just focusing on attitudinal data. So this is a smaller survey, right, to show kind of not just these huge expensive surveys that are only done every few years, but also working with pretty common market research vendors. We can use those surveys being done and also create these estimates down at the 1 square kilometer level. This is a map of based on late 2020, so before the withdrawal of the US military and the takeover of the Taliban. This is the proportion of the population who consider the Taliban more moderate than when they ruled Afghanistan previously. And then there's a lot that we do with this data. So this is one example of where we're working with some government stakeholders. A section of the city of Maputo was growing substantially, and they wanted to know where they should make investments in the city, where there was a chance where if the population continued to expand dramatically as it had been and was projected to, where would they not have the adequate levels of infrastructure, adequate levels of health services? Where was climate vulnerability particularly high, being in the coastal region? And so we combined a lot of different indicators we were mapping down into an index. And so you can see here, we've broken that down into neighborhoods as well. So 7 of them scoring above a 9 out of 10 for vulnerability across the city, and kind of helping identify the government where they should prioritize those investments. And then we also scored it based on climate vulnerability, poverty vulnerabilities, and poor access to infrastructure, such as roads, health facilities, grid connectivity, clean water, things like that. And finally, this is what I'm going to be talking about more today, which is our work on vaccine hesitancy. And so this is, I love this graphic because it kind of just shows, this is a map of Ghana. And what we're showing here is actually a survey. We worked with a market research vendor because we wanted some more up-to-date COVID-19 data. And this is a percentage of the population that was skeptical about the COVID-19 vaccine that were also currently unvaccinated, so they hadn't received any doses yet across the entire country. And what we did with this data was this is one of many indicators, many questions we're mapping down is looking at those drivers of vaccination. Who's getting vaccinated? Why not? Where is it working well? And how can we build on those successes? Vulnerabilities. Who's most vulnerable to COVID-19? So where should we prioritize those COVID-19 vaccines? We did that especially earlier on when the vaccines were just becoming available. Messaging. How can we counter misinformation in specific locations? A lot of the data we're going to be producing is typically includes lots of information on where people get their information and what sources they trust for it. And then impact, how is hesitancy changing over time? Where are our interventions? Sorry, my text is not on my keyboard. But great, we're on to the next slide anyways. So the big question, though, of course, that I want to talk about is the how we do this. And the basic answer to that is we take two different data sets. The first, the primary, where our indicators are coming from, is rigorous household survey data. So these are nationally representative, rather high sample size, geotagged household surveys. So with the Demographic and Health Survey or the World Bank's Living Standards and Measurement Survey, from these open data sources, we're able to take those, and because they're publicly available, because they have location-based data, we can include that in this process. And then we combine it with Earth observation data. And so this is also publicly available data coming from satellites all around the world, especially things from the North American Space Agency, the European Space Agencies, and others. So all of that satellite imagery, and it's not just maps, which it is, but it's also all of the data that's being remotely sensed by those satellites. So the process can include up to 200 different publicly available Earth observation indicators. So things like nighttime illumination, elevation, building density, soil characteristics, and many more. And we're running that through a series of different machine learning models. We've built a software to combine these different machine learning models and all these variables and rigorously evaluate and output this data much more quickly than is typically possible. So we're able to run entire surveys very quickly and produce hyperlocal estimates that we feel are very robust and reliable down to the 1 square kilometer level. But even these machine learning models, building on a lot of publicly available research, a lot of publicly available known models that have been tested in many different contexts and in many different research papers through different teams, different use cases. So again, we're bringing together all of these different sources, and really what we're doing is automating the process with our software to just make this ability to estimate survey data much more quick, efficient, and affordable. I'm going to pause there really quickly if there's any questions before I move on. Okay. So the use case I want to walk through today is, oh yes, please.
I want to ask, this sounds interesting and exciting. And yes, so I want to ask, how do you suppose, I think you mentioned at the point, superimpose the geospatial data, especially the one you did at Obuasi. You wanted to know a bit of how people's response to COVID-19 is, how it's skeptical with the geospatial.
Sorry, I wasn't able to fully hear you. You were breaking up. I'm not sure if you were able to hear, Catherine.
Florence, I think we missed some of
Yes.
that. Do you want to try again or type out the question?
Okay, so please, I can ask at the end of your presentation or type it out.
Okay. Sorry about that. I think the internet just slipped for a second. But yes, please, I'm happy to answer in a second once it's available. But so this use case I'm going to go over is how we use this data to increase COVID-19 vaccine uptake across sub-Saharan Africa. So We did this in 10 different countries. And I love this slide because I think it does a really good job, again, of showing where the data that was publicly available initially started out. So there was a lot of dashboards available in many different countries. We saw lots of different COVID-19 dashboards on vaccines, vaccine hesitancy, and early on case rates. And so this view in South Africa, this first image here, we've got COVID-19 vaccine hesitancy at the first administrative level. And so this is about as granular as most of those dashboards were. They rarely went below a national or first administrative level. And even if you just see here in Cape Town, where we've got higher levels, or this municipality over here, where we've got higher levels of vaccine hesitancy, just zooming into that one, you can see the same outline here, breaking this down into the next administrative level. There's a massive amount of heterogeneity that is lost even within different areas of the country. And then as we zoom in further, right here into this blue highlighted area for Cape Town, that's this last image here. Now we're seeing neighborhood by neighborhood heterogeneity or variability in the data. So we can see there's actually certain neighborhoods have fairly high levels of vaccine hesitancy, whereas other neighborhoods have much lower levels of vaccine hesitancy. But if we're just making our decisions, especially at the community level based on these survey aggregates, we're missing all of that nuance. And so we did this not just for vaccine hesitancy, but as I have listed here, it was levels of vaccine uptake, vaccine hesitancy, vaccine access, and trust in the vaccines, the concerns and beliefs in the COVID-19 disease itself, and then the consumption of every major newspaper, radio station, television station, and social media channels, all equally down to this 1 square kilometer level. And what we did with this was we wanted to not only just see where vaccine hesitancy was, but we really wanted to help the partners we were working with all around the world understand what the determinants of vaccine hesitancy were and how to address vaccine hesitancy effectively to more rapidly increase uptake. But we also didn't want them to be overwhelmed with data. So we used the kind of WHO supported 3 C's model of vaccine hesitancy, which buckets it into confidence, convenience, and complacency as the 3 determinants. And so you'll see here, we've got illustrative indicators under each of those buckets. So confidence having to do with, a person's belief in the efficacy, the efficacy and safety of the vaccine, confidence in the health system and the staff that they're interacting with that are delivering these vaccines. Convenience has to do with, do I perceive that vaccines are available near me? Do I associate a cost with them that I can't afford, whether that's a direct cost or even just a cost such as having to take time off of work, pay for public or private transportation to a vaccine site, all of these types of costs that can be included in that process, especially for multiple trips. The location, how convenient it is for you to get to that location. Do you understand the process? Is it convenient? Is it manageable? Or is it more opaque and you're not even sure how to register for a vaccine? And then the appeal of the services. Do you feel safe getting to those locations, going through those services? Are they quality services? Are people treating you with respect? Are they answering your questions? And then complacency. So this is looking at, do you actually believe in the disease? But also, are you worried about it? Are you worried about it personally? Are you worried about how it might affect your friends and family? Do you see it spreading in your community, or are you worried about it spreading in your community? And so we took all of those indicators that were fell under each C, and then instead of mapping just all of the individual indicators, as I showed in some of those early maps, we actually created an index to map all of that kind of nuance of confidence across the country, convenience, and complacency. And then what we did is we wanted to kind of now further, that was useful sometimes if we wanted to just address only confidence or only, convenience. But what we realized is there's a lot of patterns of these different drivers, of these different determinants. So we were able to then segment the entire population based on the levels of their C's. So what they were scoring, we put them into these categories. And so, for example, vaccine enthusiasts, early on, we saw these as the people that had they had high confidence in the vaccine. They assumed it was going to be readily available for them, and they were concerned about COVID-19. So they had low levels of complacency. And so this is, the type of group that if you've got a limited amount of vaccines, You want to know where these groups are and how to reach them, because they're going to be the quickest to take the vaccine with lower concerns. And then we had this going to pragmatists, ambivalent skeptics, and cynics. So all the way to, I've got low confidence, high complacency, and we put moderate here because often in these cases convenience wasn't really a factor. It was, we had some people in these groups that had high, low, and medium convenience. It just didn't seem very significant. What was the driver was really having both low confidence and high complacency. Made you a vaccine cynic, so you were the least likely to take the vaccine because you didn't trust it and you weren't worried about COVID-19. And then just the same, we mapped each of those segments down to the 1 square kilometer. So now we have different groups that we can target based on what their concerns are. So based on which segment, we can think of different messaging, different outreach efforts. Sometimes it's going to be messaging, or sometimes it's more about convenience. So it's about making vaccines more readily available, or creating new pop-up sites, new clinics where vaccines are being administered that weren't previously available. And we were able to also break this down by the vaccinated and the unvaccinated. And this is a use case of that, which I'll show a little bit more in the demo. But taking these segments, or if we wanted to just look at the indices or the total vaccine hesitancy, but in this case we looked at just vaccine skeptics. So we're looking for people that don't trust the safety of the COVID-19 vaccine or efficacy of it, or the efficacy of boosters. So these are people who are already vaccinated in high inventory areas. So where do we have a lot of vaccines that are maybe going to expire soon if they're not used? And so we want to find this group that hasn't yet taken vaccines, or has taken vaccines but has become more skeptical over time, which we find was happening. So where do we find them? We found them, for example, in greater numbers around the Tamale metropolitan area, but they were concentrated in different neighborhoods around the city center. So again, if we took just a city approach, we've got entire areas with much lower levels of that population that it wouldn't be very efficient to work in, but other neighborhoods where there should be expert resources prioritized if we want to reach this population. And then looking at that, we looked at, okay, for this population or in this area, what type of media is being consumed in Metro Tamale? And so we saw Facebook users and WhatsApp users were rather a high percentage, whereas radio listeners for some of the major radio stations were lower in these areas. TV3 was a pretty significant channel useful for outreach. And then we could also look at what's the most common news source people were using to get their information. And it happened to be social media. So we know that, even if Facebook's a little bit lower than TV3, we might want to start on reaching out on Facebook, because that's going to be a common source of information for people for whenever they are on Facebook. And so just kind of in summary there, then it's with this hyperlocal data produced from many different publicly available open sources, we're able to zoom into any neighborhood or remote community to better understand population characteristics, perceptions, behaviors, and underlying drivers. We can segment and target populations based on demographic, socioeconomic, and attitudinal characteristics, as well as their access to different media channels. And with this, we can improve health outcomes, things like gender equity, food security, and much more through optimized resource allocation, improved project design, and community outreach. And one thing I didn't stress here is that with this data, and I'll actually show when I switch to a demo what this looks like, but we did share this data. We didn't share it completely openly because of the granularity and because of the sensitivity around attitudes around COVID-19. We didn't make it publicly available in the sense that anyone could get access to it. We took what we call, and I'm not sure if there's a better word for this, I'd love to hear it. We used what we called a semi-public good model. And so this data was available on an interactive dashboard for anyone without any charge that was actively working on increasing vaccine uptake in the countries who produced this data, which was 10 different countries across sub-Saharan Africa. And so this ended up, we had a tremendous number of users coming from international and local NGOs working in these countries, a lot of donor-funded organizations, donor funded by USAID or UN agencies or other private like Gates Foundation donors. So these are the types of partners we were providing this data to. So it was kind of a semi-open in that, as long as the data was being used by a verified entity in the way that it was intended to be used, we were giving them access to it. Before I jump into a demo, though, I'd love to take a pause and take any questions.
I think there's some specific questions about locations that you've looked at. So I'm not sure if you want to circle back around to those kind of. But otherwise you can run through and then we can maybe have some Q&A at the end, because I think you'll have a lot of follow-ons.
Yeah, I'd say, well, and for the specific location, I was thinking, I don't know of any specific work because unfortunately we're a pretty small team. And so what we've kind of taken the model of doing is training others how to use this data. So I'm not actually aware of every single use case for this data. We've been requesting our partners come back and share success stories, share how they've used the data. I've heard a lot of great examples. For example, in Nigeria, one of the large USAID-funded projects was using it to inform all of their outreach activities. And this is a massive project, and they were also informing the national and subnational government entities on all of their outreach and how to prioritize vaccines for the most vulnerable communities that weren't typically getting access to them. And also how to allocate vaccines that were going to expire all around the country to those areas where there was going to be the highest uptake the most quickly. And many, many more use cases like that. But I don't have many examples of specific locations because those were typically done by kind of smaller on the ground teams. And often they were working with a larger partner who was kind of giving them the insights, right? Using our dashboards, using our data and helping them tailor their activities further. But it was a bit removed from working with us directly.
Okay. Well, I think that's one question that I have is, when you get to scale with an organization like this, how do you have the quality control? How are you working with local partners to ensure that you have sort of uniformity in the data that you can compare across different regions and across different countries? I've worked on demographic health survey from the USAID side, and that was an issue itself is, when you have different contractors, unless you're very clear about what kind of data, how to collect it, how to ask it, and then how to analyze it. Unless you have that uniformity set out in the beginning, it's very easy to have different kinds of data that comes back, which can be hard to analyze. And I wonder how you all have reconciled that while still trying to be adaptable to learning, because you want people to be able to ask questions in a way that make the most sense to their communities. You want the analysis to include, potentially other data sources that could be helpful. But so there's a balance between how much do you go local and how much are you trying to do sort of trends and comparisons across different countries in a wider or just a wider geographical area. Dennis, you wanna jump on top of that one? Go ahead.
Yeah. I have a number of questions. Because I've seen the two major data sources include the survey data and Earth observation data. So my question is, do you do the survey yourself or do you rely on maybe government portals? Because like here in Kenya, we have the data portal by the government. And so that's one. How do you ensure that about the data freshness? Now going with if I assume you're using the portal by the government, because that data is always sometimes outdated. So how do you ensure that you're getting fresh data? My other question is about data privacy, because now you work across different regions, different countries. Here in Kenya, we have our data protection law. South Africa, they have the POPIA, we have GDPR. So how do you ensure data privacy across different locations that apply to those areas? And finally, who uses the the analysis results that you find? Is it the government? Is it NGOs? Or how does it impact the common citizens? Thank you.
Yeah, great questions. So I'll start on kind of the data piece, because we also have a question in the chat, how we collected in Ghana, whether it was remote or physical. So just on collecting the data in general, we've got the two methods. One is to use publicly available data, and we're only going to use sources that are extremely robust. So, Catherine, we mentioned that even the DHS has significant challenges running a survey, on the ground, such large sample sizes over a long period of time, working with a lot of different contractors. But we do consider them an extremely reliable source, along with the World Bank surveys. And so usually if we're going to use an existing survey, it's coming from that we haven't had any input on, it's going to come from a source like that. If we're working with a partner, so for example, on like a USAID funded project, we are working with perhaps as a subcontractor to a much larger organization or larger NGO, and we're informing their data collection process. If they're contracting it out, kind of informing the RFP and all of that. So we're making sure that we are getting extremely representative samples. We have nested quotas by gender, by region in the country, by age, and then we often also are looking at least nationally, socioeconomic their characteristics as one of those as well, one of those quotas as well. And so as a result, sometimes the requirements are much more robust. The sample sizes are also typically much higher. I think in Ghana, it was probably around 4,000 to 6,000 sample size, which is why often we're using random digit dialing and computer-assisted telephone interviews over mobile phones when possible. And we're able to do that in a lot of different countries in Africa pretty robustly, particularly because we're using this quota system, because we're allowing our sample sizes to be so high, and because we're running those surveys with dedicated vendors that have in-country staff that are speaking and translating in local languages, and kind of walking through answering questions as needed. But a big part of it's also automated, right? So it's kind of a quasi-human direct, whereas there's also a component of automation through those surveys to run them more quickly and make them less labor intensive for the recipient of them. We try to keep them under 20 minutes, for example, at the most. And that's probably our most common. In Ghana, for example, it did take longer than expected because we were having trouble reaching the most rural parts of the country, the lowest socioeconomic status individuals in the most rural parts of the country were particularly difficult to reach in Ghana. And so we had to run that survey for much longer than expected so that we could reach all of our quotas in those regions for lower socioeconomic status individuals, because they often didn't have access to mobile telephones. So we had to find other ways to reach them or get access to them through shared phones, things like that. As for, data uniformity, that speaks to that as well, right? So we're typically only working with one vendor. We don't usually do in-person data collection, which allows us to keep a lot more uniformity. And if it's some countries we've worked in India and China, we've actually used online panel surveys. We're working with vendors that already have panels set up with very large sample sizes that are representative across all of the characteristics we need. And so we're able to get really robust surveys from there as well. And then if we're running a survey on the ground where our partner, right, our project partner is doing in-person data collection, then we're just informing all of their methodology, and it might not be national in that case. Usually there's not enough budget for a national survey that's run in person with that high of a sample size. So then we're doing more just at the district level or something like that. We're creating those estimates only for that district because the sample just has to be representative of any geographically bound region. It doesn't have to be a country. It just most often is. We prefer to produce our data at scale within a country. As for data privacy, the key here is we never collect personally identifiable information, and we ourselves never collect GPS locations. So when we work with our vendors, we insist that they never, they might have, we're only working with some of the most reliable and well-known vendors. So they have their own methods for making sure that they're not storing any PII improperly. Anything they give us, once we get those surveys, there's no names, there's no addresses, there's no telephone numbers. We do have location data, but even that is then usually collected through different means. So instead of a GPS location, we're asking questions within the survey, which starting from the first, the second, to the third administrative level, and then asking for, it really depends on the country, right? We might ask, what's the nearest school to you? What's the name of the nearest school, the name of the nearest health facility, what's the name of your village, the name of your town? So we'll ask some of these other questions so that we can then cluster, and our survey vendors can cluster all of the responses within a very small area into the same cluster. And so we only know where that cluster is about. We don't know where the individual responses came from within it, and we don't have any personally identifiable information. We think it's really, really important that we don't ever get access to that data. We don't want the risk that comes with it, and the potential for mismanagement or misuse in any capacity, even accidentally. So it's something we strive really hard to make sure doesn't happen. And then on use, who's using this? I mean, yeah, I would say most commonly, we've been working with, I would say the US government is using it a lot, right? Some of the different donors and agencies of the US government is a big supporter or funder of ours. But even more often than that, probably NGOs and contractors that are funded by agencies like USAID or the State Department. As well as, we've done work with UN agencies directly providing them this data, and just some of the big NGOs that are, funded by multiple, different direct donors, different partners. So they have projects that the funds come from many different sources, but they're using our data directly. Less often, we do sometimes work directly with government agencies in the countries where this data is being produced in, but we usually need support because we are a small team. When I started 3 years ago at Frame, we were probably around 30 people. We're now a little bit over 50. We are located a distributed staff around the world. We do have people in Berlin and Nairobi, California, and many other locations, but we're mostly in the DC area or the northeast of the United States. And so we're working online, and so we're training our partners. We're getting on teleconferences with government agencies, training them up on how to use our data, how to think about it, how to use the dashboards we're putting together for them, or working directly with them to integrate the data into their existing systems. But for the most part, it is more a training of trainers method, where our partners, these larger NGOs or larger international organizations, are the ones that we're working with directly, and then they're taking those insights and helping others use it, including the many local organizations they often work with. That's a common way that local NGOs in the country will be able to use our data, either our data directly, the raw data, but often it's taking the insights from it and packaging it in different ways. Whether that's an interactive dashboard, or if it's kind of more reports that really walk you through all the insights and findings and all the analysis our team did to make those policy recommendations or resource allocation or activity design recommendations. And all of that would be done in partnership with different donors and different NGOs we're working with. Have the country context.
And I'm sorry if I missed this, Kenneth, but did you address the real-time question about the data, but how to keep the data current?
No, I didn't. So historically, we relied more on DHS, so we didn't have current data. The benefit is there's not much current data that's really representative. So a lot of times the DHS is used for many, many, many years after it's run, and it's used for planning and decision-making, resource allocation. So one benefit is that a lot of those indicators are foundational. They don't change very significantly. So all of our like demographic, socioeconomic, key kind of health metrics These typically don't change very rapidly, and so we find that that's useful for a long time, which also makes our data typically more sustainable because it can be for several years once we've produced it. But we did find that to be a major limitation, and that's one of the main reasons why we started working with survey vendors. We never do collect data ourselves, but we work with vendors to make sure that we're getting more up-to-date data. And now we actually, in the countries we work most often in, and we've worked in over 100 different countries at this point, we run data at least annually. So we're kind of making sure everything updates annually, but often even quarterly. So we'll get quarterly updates of all of these square kilometer estimates of the data. So for COVID-19 vaccine hesitancy, for example, most countries were only funded to produce that data once, but in Kenya, for example, we were able to produce it towards the end of, or towards mid 2021, and then at the very beginning of 2022. And that with that, we're able to actually map change over time for all of the, not just vaccine hesitancy, but change over time of the segments we produce, of the indices we produce, which is really interesting because we saw things like confidence in the vaccine plummeted in a lot of communities. And we realized it's likely because of the Omicron variant, because one of the questions we were asking is, do you feel that the vaccine will be effective against future variants in protecting your health? And with Omicron, a lot of people saw that people that were vaccinated were now getting COVID-19. So confidence in the vaccine plummeted, and a lot of the segments people were in shifted, even people who were previously, enthusiasts of the vaccine or now maybe a little bit more skeptical.
Lovely. Okay. Well, not lovely, but thank you for the answer on it. And then just the last before you move forward, it did sound like primarily even in the very rural areas, primarily you're using mobile phones as a way of conducting these surveys. Do you have any paper surveys? Are you able to collect any information about hesitancy, misinformation for people that don't have active use of mobile phones, or perhaps are censored or kept from freely using a mobile phone?
So the answer is not typically, unless we're working with a large, well-funded project and NGO partner, and then they are doing that. We did not for vaccine hesitancy, for example. We were doing these surveys ourselves, and that's why we just do everything we can to make sure we're running the survey long enough and providing incentives, reaching out, through different channels to get people to be willing to take those surveys on a phone, even like I said, if that requires getting, access to a shared phone or something like that.
Thank you.
But of course, the goal is that, with this, if we can get a sample of enough people that in this region, that are women of a certain age bracket and a certain socioeconomic status, the idea is we only need, so many of that group in clusters all around the country to then produce the estimates for all of the individuals we weren't able to reach as well. And there's a lot of methodology that goes into verifying that, right? So where we have really known data, where we don't have any gaps, we actually will remove up to 75% of our data, and then train our machine learning algorithms on that, and then ask that, have our software estimate where we have known data. And so we'll then compare those estimates to what we know really it should be in that part of the country. And then we also will compare it to other data sources we have. So when we do have, a survey that's available at the level, or census data, or when we compare it to a recent DHS, we do a lot of manual, kind of oversight to make sure everything is as robust as possible. And we do tell our partners this is not perfect data. There's no such thing as a perfect survey. But the feedback we've gotten, and that's made us more and more confident over the years, is that this is so much more useful than what's available out there. And so even with those caveats, and we do look at it at a regional level. So each of those indicators that we're providing to our partners, we'll let them know if we're not very confident about our predictions in these communities for this specific indicator, because our tests are coming back as if being just a little too off for our confidence intervals just aren't quite tight enough for us to be confident about those predictions. And so we let them know that, and that they should be used, cautiously. But we're much more confident about them in every other part of the country. So, we want to make sure that it's available. And if it's really beyond the point where we think it's safe and reliable to use, then we will gray out those parts of the country for those indicators, for those models. So please feel free to keep jumping, adding questions. I want to just show a really quick demo of the dashboard. Probably should just take 5 minutes before we leave. Just to kind of show what the partners had access to. And if you or someone is working on vaccine hesitancy, I can always work with you to get access to these dashboards. But so this is it in Kenya. Again, this is county level. I start here just looking at vaccine hesitancy because this is as granular as it was available in most countries. But even just bringing this down to the ward level in Kenya, you can see this whole region here is red, showing a higher level of vaccine hesitancy. But then breaking it down to the ward level, we see a lot more heterogeneity here. Certain areas of the country, certain pockets stand out with bright orange here in a sea of lower levels of hesitancy. And we find this heterogeneity for the vast majority of data we're producing. There's just such local variation. Of course, bringing it down to what we call the grid level. That's again just a neighborhood by neighborhood, a 1 square kilometer level for these data sets. So now you can see that same map, same vaccine hesitancy map, but now it looks very, very different. We're seeing neighborhood level variance, and we can kind of zoom in to a specific area of the country. We can, we have COVID-19 vaccination sites as of May 2022, so a lot of date now, but that's when this project was kind of running. And so then we can see here's where we have known vaccine sites, and so if we want to understand the population around those a vaccine site, we can just grab a custom catchment area, for example, or we can produce, kind of standard catchment areas based on distance. And now we have right here in this report, because each of these pixels is a data point, right? Each of them has a value. And so now by grabbing all of these pixels together, I'm seeing in this report here, this selection column is aggregating all of those estimates. So the population here is about 11,000. And then we can see levels of vaccine hesitancy. I've got a few indicators turned on 52% of people in these communities are Facebook users, 33% of them speak Swahili, only 3% are Muslim. And then we're comparing it to the ward. And because I selected in multiple wards, it's actually, averaging or combining for all 3 of these wards. But if we were to select at the ward level, at the county level, it's always going to compare it to the next level up. So you can kind of see what at the county level, you can compare it to the national level, for example, any of this data. And one of the particular use cases for this that when we turn off health facilities, it's actually because a lot of decisions aren't made at a 1 square kilometer level, at least not early on, but they are made at administrative levels. And again, this third administrative level in Kenya, the ward, or like when we work in Ethiopia, the Wareda, these are so far more granular to make decisions at than at like a county level, for example, that it's been really transformative for our partners. The one example is just being able to say, okay, I want to go here. I want to understand this pocket of vaccine hesitancy. And so I'm going to, turn on I want to see, actually I'm just using low confidence. So this is actually like how many people have low confidence. So rather than using it as a score, we're just seeing the people who kind of fall into the low confidence, low convenience, or high complacency brackets. And then I want to see, some of these key channels, who's using them, how can I reach people? So this one would be good to do. TV. And then where the language is being spoken. And so this is actually the primary language spoken at home, which we asked specifically because we wanted to have an understanding of, we figured sensitive, controversial sometimes health communication should be done in the language that people are most confident in. So this is the language they speak at home. I'll leave it at that. And so that's all I had to do now to add a large number of additional indicators to the report, so I can kind of see more information about this community. And I see that, you know, compared to the county level, it's got much higher complacency in this this particular ward. But it's actually got lower levels of, or it's also got lower levels of convenience and about the same levels of competence. But so if I want to do something to address complacency, now I already know kind of that might be what the best and most impactful messaging content will be. So if I want to reach out to this community, I want to talk about the threat the disease has to, you know, the elderly population in their community, to friends and family. I want to talk about things like long COVID, that even if you don't get really sick, it's still a threat to your health long term if you're not vaccinated first when you get sick. And then, okay, but how do I want to reach out to this community? One of the things that stands out to me really quickly here is Radio Citizen. It's 55% of people in this community listen to Radio Citizen on a regular basis. Only 40% for Facebook users. So probably Radio Citizen would be my best use case here. And then if I want to look at languages spoken, okay, what do I want that advertisement, right? That radio ad talking about COVID-19, the disease, and the risks of it. What language? Somali is going to be, you know, what I want to use. And then I know, which makes sense, this is a predominantly Muslim community. So I might also want to be appealing or using local religious leaders, or appealing to traditional Muslim values about community to kind of tailor that messaging even further. And so that's great. I know exactly what to do in this single ward, but now I want to know if I were to run this ad, this specific ad in other locations, where would it make sense to add them, run them? And so I'm going to look at, right, Radio Citizen, 55%. So I'm going to filter only to communities, only to arrays where at least, let's say, 35% of the community listens to Radio Citizen. And because I'm running this ad in Somali, I want to also filter only to communities where at least 50% of the community speaks Somali at home. So I'm going to apply those changes. And now I can see, here's all the wards that ad would be useful to run in based on those parameters. And I can even further tailor, right? If I want to just focus on high complacency areas, because that's one of the things we identified earlier, you know, I could say I only want to see places that are 40% high complacency. And so now I know, you know, this is where this ad is going to be very effective, and I can still see this base heat map of hesitancy, right? So I know that these red wards are going to be where there's higher levels of hesitancy relatively compared to the green ones. So if I want to prioritize based on hesitancy as well, I can very visually do that, or I could filter it just the same. But it's the speed that our partners have said has been really transformative for them, because to get to this level that just took me a few seconds of kind of thinking through a new campaign would have taken a significant amount of time to kind of think this through at a ward by ward strategy. And if we're using something like social media, like targeted Facebook ads, then we do want to switch into the grid level, because those are really easy to geographically target. So we do want to see kind of the heat maps. We don't care about the boundaries of the wards. We just want to find the communities where our messaging will be most effective. So that's another popular and effective use case our partners have shared with us. And it's then being able to say, okay, but what if I run this exact same ad, same content in another language? So I want to see what other areas of the country, and that's most, right? Most would also, you know, based on these parameters, be effective. So I can go in here, say, here's another, you know, board I want to look at, and what are the languages spoken there? You know, and so I can see Turkana, 53%. So now quickly, you know, switch it back to Turkana instead and see all the wards where at least, you know, let's say, again, 35% speak Turkana. And getting a very different map, right? A completely different set of wards. So now I can segment a single ad that I've designed on a single news or a single radio station with specific content to areas all around the country in different groups. And then I can address a different type of vaccine concern. Or I can use, instead of this radio station, I could use a popular television station, or I could use Facebook, etc. So it's that ability to really efficiently allocate resources and tailored messaging that we found to be most significantly impactful. And I think we've only got 2 minutes left, so I'll either open it to questions or hand it back to you, Catherine.
Sure. I think we'll probably stack questions. So if people have questions, please ask them. But we may have to follow up with you, Kenneth, since we are, as you say, at time. Okay, feel free to ask questions on the chat or in the notes document, and we can follow up with you. I thought that was a very helpful break for questions that we had halfway through. So thank you for that, Kenneth, and help steer us. Lots and lots of good work here. And I'll defer to Kenneth if he wants to share his email with everyone. And then, yeah, great. Thank you. As we talked about PII. Right. Thank you all for joining. It is Open Data Day week. We've extended to a week this year, the community who work on open data. So I hope that you all will be involved in a lot of great events. We're running one tomorrow on internet measurement around the world. It is also Women's Month, and tomorrow is International Women's Day. So please give consideration to the work that you're doing. How are you elevating? We're looking at partnering with Wikimedia for an edit-a-thon for more women leaders, and particularly women leaders across the continent, to get their stories up. So I will leave you with that. Looking forward to seeing many of you in April. And thank you, Kenneth, so much for your time.
Thank you all. Thanks for having me.
Bye-bye.
Thank you very much for that wonderful presentation.